Okay, so today's lecture is on neurovascular anatomy, and we'll be covering part two. So, as we had discussed previously, we have discussed already the embryology of cranial vasculature, the external and the internal carotid arteries. So, the discussion today was supposed to be about the vertebral artery, the supratentorial, and the infratentorial arteries. As I was planning this lecture, I came to realize that this can be quite an extensive topic to discuss in just one lecture. So, what we'll do is we'll cover these arteries, but we'll take a separate class on the ACA, the MCA, and the PCA. So I would like to cover those in a little bit more detail in a separate class. Otherwise, we'll just cover everything else in this lecture itself. So starting off with the anatomy of the vertebral artery. The vertebral artery originates from the subclavian artery, and it has four very well-known segments. The V1 is going to arise from the subclavian artery, and it is going to enter the C6 transverse foramen. So that is the V1 segment. The V2 segment is going to be running through all the transverse foramina of the different vertebrae from C1 to C6. The V3 is going to run from the C1 transverse foramen all the way up to where the artery enters the dura. And the V4 is the intradural segment. The V1 segment is also called the austere segment, and it is going to, as we have discussed, it is going to be from the origin of the subclavian artery till the entry into the C6 transverse process. It is differentiated from other branches of subclavian artery by having a complete lack of any proximal branches. So you can differentiate from the thyrocervical trunk and the ascending other branches which are in this region, like the ascending cervical artery, from a lack of any proximal branches. In a study of 700 vertebral arteries, it was found that 94.9% will enter the C6 transverse foramen. In about 5%, the artery will be entering this transverse foramen at another level. So that could be either C4, C5, or C7. And in C4, it enters at about 1.6%. In C5, in 3.3% of cases. And in C7, at 0.3% of cases only. The V1 segment is situated in the triangle of the vertebral artery, and that is bounded, as we can see here. That is bound, I'm sorry, with the lateral edge of the longus colli located here, the medial edge of the anterior scalene, and the first part of the subclavian artery located over here. So within this triangle, you can find the vertebral artery first segment. This vertebral artery, which is located over here, not been completely dissected in this diagram, is situated behind the internal jugular vein, the common carotid, and the vagus nerve. So it is located behind all these structures. It's located between the longus colli, as we saw, which is here, and the anterior scalene, which is over here. And it is going to be located anterior to the C7 transverse process. So when you're dissecting this area, you can use these structures to identify where is the V1 vertebral artery. And it will be crossed in front by the inferior thyroid artery and the thoracic duct on the left side and the right lymphatic duct on the right side. It will be also looped around by the ansa subclavia from the sympathetic chain. As we can see here, that is the structure. The important aspect about the V1 is that it is, unlike the other parts of the vertebral artery, quite unprotected by bony structures. And whenever you're dissecting these muscles, you can end up injuring the vertebral artery in this region. The V2 segment, as we have seen, is the part which is entering through the C6 transverse foramen and running through all the transverse foramina of the different C1 to C6 vertebrae. It is here covered by the intertransverse muscles, and it lies in front of the cervical nerve roots. It is also accompanied by a plexus of nerves, and that is from the inferior sympathetic ganglion, which run along when the vertebral artery is entering the transverse foramen. It is also covered by a venous plexus, which will end up forming the vertebral vein. The the V2 segment is supposed to actually end after entering the transverse foramina of the atlas, but some authors also say that the V2 segment is only up to the C2 transverse foramen, and the part from the C2 transverse foramen upwards is the V3 segment. From C3 to C6, since it is running the transverse foramina there, it lies about 30 millimeters lateral to the midpoint of the vertebral body and about 2 millimeters lateral to the uncinate process. After, as we can see here, the C3 transverse foramen has to run laterally to be able to enter the C2 transverse foramen and even further laterally to be able to enter the C1 transverse foramen. The V3 segment, as we know now, can according to different people, arise either after having entered the C2 transverse foramen or after having entered the C1 transverse foramen. So most commonly, it is still described as after having entered the C1 transverse foramen. So up till here, at this point, it is still going to be the V2 segment. So the V3 segment extends from the transverse foramen of the atlas up till the site at where it enters the dura, which is over here. This, as we can see, is a very unnecessarily tortuous and complicated course for this artery. So it exists in this way so that there is a significant redundant portion of the artery which is available to allow for neck rotation. There are three portions within this V3 segment of the artery. One is the part which ascends through the transverse process, that is a vertical portion. There's also a horizontal portion which runs behind the C1 lateral mass on the upper surface of the posterior atlas arch, and an oblique portion which is over here, which is going to penetrate this dura. So the V3 segment also lies in a very important anatomical region that is known as a suboccipital triangle. The suboccipital triangle is formed by three main structures. One of these is the rectus capitis posterior major, as we can see over here. And the other two structures would be the inferior oblique muscle and the superior oblique muscle. The superior oblique muscle is going to be over here. So within this triangle, there's the floor of the triangle is bound by the atlantoxviral membrane, and over that we can see the vertebral artery V3 segment running. So after dissection, as you can see here, this is a suboccipital triangle. This is the rectus capitis posterior major. This is the inferior oblique and the superior oblique. And so if you dissect this region, you'll find the vertebral artery over here. The V3 segment also courses posterior to the lateral mass of C1. As we saw, the horizontal portion is going to be coursing behind the lateral mass of C1 after it exits out from the C1 transverse process. So here it is going to be related to the C1 nerve root, but also it is running in one shallow groove right behind this lateral mass. That it is going to be a shallow groove only in about 50% of cases. In the other 50%, half of it is going to be converted into a bony ring, which is a partial ring, so it's not a complete ring. And in about 28%, that ring is complete, forms a complete bony ring. The terminal extradural vertebral artery over here, the last part of the vertebral artery, usually gives rise to the posterior meningeal and the posterior spinal branches. It also supplies the branches to the deep cervical musculature as well. So the distance between the midline and the point at where it is going to enter the dura is said to be about 12 millimeters. Finally, the last segment of the vertebral artery is the V4 segment, and the V4 segment begins where the artery is going to penetrate into the dura. So this is located just behind and below the foramen magnum lateral edge. Here, the dura is going to be a little bit thicker than the other areas of the dura, and it is going to become slightly funnel shaped and cover about 4 to 6 millimeters length of the artery. Apart from the vertebral artery as well, there are going to be other structures which will be passing through this foramen. So that will be the C1 nerve root, which is exiting out from here, and the posterior spinal artery, which is arising from the extradural segment most commonly of the vertebral artery and trying to enter into the spinal canal. So after entering into the intradural segment, then V4 segment will run above the C1 nerve root. It will run anterior to the posterior spinal artery and the dentate ligaments and the spinal accessory nerve. So it's going to lie in front of all these structures because it is to come anterior to the brainstem. So as we can see here, after it has penetrated the dura over here, it is running in front of this dentate ligament, as we can see over here. It is running in front of the C1 nerve root, and it is running in front of the posterior spinal artery. So all these structures are important to identify and preserve, except for the dentate ligament, of course, when you're trying to access the V4 segment of the vertebral artery, which is lying in front of these structures. The V4 segment is also divided into a lateral and an anterior medullary segment. This is based on the pre-olivary sulcus. So the part of the vertebral artery which is lateral to the pre-olivary sulcus is going to be the lateral medullary segment, and the part which is medial to the pre-olivary sulcus will be the medial medullary segment. The vertebral artery will join with its opposite side at the pontomedullary junction and form the basilar artery. There are two groups of branches of the vertebral artery. One is a cervicospinal group, and there's one cranial group. So there are the cervicospinal group is basically the arteries which are going to be supplying the cervical spine. So these include the lateral spinal branches. These are basically radicular medullary branches which are going to be entering through the intervertebral foramina, and they're going to be supplying the nerve roots and spinal cord, and even the vertebral body. There are also muscular branches which are going to supply the deep muscles of the neck. The important aspect here is that these deep muscular branches can also form anastomoses with other arteries, like the occipital, the ascending pharyngeal, and the cervical arteries, and this can become problematic in certain instances. There's also a second group of branches of the vertebral artery, and these are known as the cranial group, and these include the following arteries. The first one is the posterior spinal artery. The posterior spinal artery most commonly is going to arise outside the dura mater as we saw. It is going to penetrate the same foramen in the dura as the vertebral artery does, and then it is going to run behind the dentate ligament. So the important thing here is when you're trying to open this dura around the vertebral artery, you might end up injuring the posterior spinal artery. Once it enters and runs behind the dentate ligament, it will then divide into an ascending branch which will go up and a descending branch which will go down. The ascending branch will supply the dorsal part of the medulla. The descending branch will pass between the dentate ligament and the dorsal rootless and supply the spinal cord. The most important branch of the vertebral artery is obviously the pica, and we'll be discussing this in a lot more detail later on. The other important branches are the anterior spinal artery, and this arises intradurally. It's going to arise from the vertebral arteries we can see over here, quite near the origin of the basilar artery. The other two important arteries are the anterior meningeal artery and the posterior meningeal artery, supplying the dura. So the anterior meningeal artery is going to arise from the vertebral artery at just above the level of the C3 transverse foramen, after which will supply the dura of the clivus, the anterior foramen magnum, and upper cervical spinal canal. And it is also going to be ending up supplying the meningiomas and other dural-based tumors arising in these regions. The posterior meningeal artery is going to arise from the vertebral artery, on the other hand, at the level of C1, as it is coursing around the lateral mass of the atlas. So that is all we would like to discuss about the vertebral artery and its branches. Going on to a discussion of the supratentorial arteries. So as I already mentioned in the beginning of this lecture, we will not be covering all the supratentorial arteries. We are going to be discussing the ACA, the PCA, and the MCA separately because it is a long and extensive topic and we would like to understand that in quite a bit of detail. So here we'll just go through all the other arteries arising from the supraclinoid ICA and just what we can learn about them. So supraclinoid ICA, as we've discussed in the previous lecture, this is the Roton classification. According to the Roton classification, there is four portions of the supraclinoid ICA. There's a C1 or cervical portion, the petrous portion, the cavernous portion, and the supraclinoid portion. So the supraclinoid ICA is going to be the part of the ICA which is running above the clinoid process. So it is going to course medial to the anterior clinoid process, and it will be below the optic nerve. And then, as we know, how it courses along the carotid siphon, it is going to run posteriorly and laterally and superiorly. And then once it comes to the bifurcation, it will bifurcate into the ACA and the MCA. This region from which the ACA and the MCA arises, crotch over here, that is also supposed to be part of the ICA. And any aneurysms arising from this region are also considered to be ICA aneurysms itself, or specifically ICA bifurcation aneurysms. The supraclinoid ICA is usually exposed by going through the terional route or even by an orbitozygomatic exposure, depending on how much exposure you need. The surgical exposure of supraclinoid ICA usually is going to be from proximal to distal. You're going to look at the optic nerve, identify the carotid artery next to it, and then you're going to be dissecting distally and identifying all the different structures. The ophthalmic artery, which is the first branch of the supraclinoid ICA, is going to be quite difficult to expose because it is a very short intracranial course and it is present below the optic nerve. So that can be quite difficult to expose. The first artery you will usually see arising from the carotid artery is going to be anterior choroidal. Even though the PCOM or the posterior communicating artery is going to be arising first, the first artery we will usually see is going to be the anterior choroidal. And this happens because of three reasons. One is that when the ICA is running posteriorly, after passing next to the anterior clinoid process, it passes in a slightly posterior lateral direction, and that makes the anterior choroidal artery, which is rising more distally than the PCOM, become more lateral than the origin of the PCOM. So since we are approaching from a lateral direction, we're going to be seeing the anterior choroidal more before you will see the PCOM. The anterior choroidal artery will also be rising more laterally on the posterior wall of the IC than the PCOM will, and the anterior choroidal is going to be running in a more lateral direction. So all these reasons are why we will end up seeing the anterior choroidal before you end up seeing a PCOM. The C4 segment of the IC is divided into three different segments: the ophthalmic segment, the communicating segment, and the choroidal segment. The ophthalmic segment is what is between the ophthalmic artery up till the origin of the posterior communicating artery over here, and this is the part which gives rise to the ophthalmic artery itself. The communicating segment is from the origin of the communicating artery up till the origin of the anterior choroidal artery, and the part from the origin of the anterior choroidal artery till the bifurcation of the IC is known as the choroidal segment. So the longest segment, as we can see, is the ophthalmic segment, and the communicating segment will be the shortest segment of the C4 segment of ICA. Okay, so this can get slightly complicated, but it is important to understand what is the basic fundamental idea of ICA perforators and why they're important. About 8 perforators will arise from the supraclinoid ICA itself, and most of these perforators are going to be running medially and downwards, and they're going to be predominantly supplied by structures we can see over here: the optic nerve, the optic chiasm, the optic tract, the pituitary, the stalk, and other structures which lie in the floor of the third ventricle. So that's the basic idea over here. Okay, so totally about there are C8 perforators rising from the C4 IC, and different number of perforators will arise from different segments. Why is this important to remember? Because when we are clipping aneurysms which arise from these particular segments, it is very important to dissect these perforators off the aneurysm wall and make sure that none of these are incorporated into the clip. So it is important to know if perforators usually arise in these regions or they do not arise. And if they do arise in this region, what are the different structures that they are supplying? So the ophthalmic segment usually has, since it is the longest segment, it does have 4 perforators arising from here. And they arise, as we know, mostly from the medial and the posterior wall. And most of them are going to be supplying the pituitary gland and the optic chiasm over here. The branches which arise from this segment and are distributed to the pituitary gland and the infundibulum are what is known as superior hypophyseal arteries. Then the shortest segment is the communicating segment, and usually in 50% of cases, absolutely no perforators will arise here. Sometimes, rarely, a few perforators may be found, and these are distributed predominantly to the floor of the third ventricle, and maybe a little bit to the optic chiasm and the infundibulum, but predominantly to the floor of the third ventricle. These, the problem here is if they are present, they will be wrapped around the neck of a PCOM aneurysm. The choroidal segment, on the other hand, will also have an average of 4 perforators, and these will predominantly go into the anterior perforated substance over here and supply other posterior structures like the optic tract. As we already discussed, superior hypophyseal and infundibular arteries are the arteries which arise from the ophthalmic segment and supply the infundibulum and the pituitary gland. So these are a group of arteries, and the largest one is known as the superior hypophyseal artery. So as we can see, they're rising from the ophthalmic segment, they're running to supply the infundibulum and the pituitary stalk. The largest one will be known as the superior hypophyseal artery, but the entire group is basically the superior hypophyseal arteries and the infundibular arteries. The infundibular arteries are predominantly going to, on the other hand, arise from the PCOM, and they will go into the infundibulum on the other hand. The superior hypophyseal arteries and the infundibular arteries will then join together and they will form a plexus, and that is known as the circuminfundibular anastomosis. This anastomosis, once it is formed from these arteries, is going to give rise to ascending and descending branches. The ones which are ascending will supply the structure above, obviously, and that will include the tuber cinereum, the median eminence, and the inferior surface of the optic chiasm. The descending branches are what is going to supply the pituitary gland. And so these are superficial and short stalk arteries. Superficial arteries will run down on the surface and they will supply predominantly the anterior lobe, but the short stalk arteries will supply the stalk. Coming to the ophthalmic artery is the first branch of the supraclavian ICA. It is the first branch of C4, and it usually, most commonly, is going to arise above the dural roof of the cavernous sinus. And so we usually use the ophthalmic artery to define which is the intradural portion of the ICA. So whatever structures are below the ophthalmic artery are at least in 90 to 95% of cases going to be extradural. 8% of ophthalmic arteries, on the other hand, can arise from the cavernous IC, as we can see over here. And then they have to run through the dura and then penetrate the dura and enter through the superior orbital fissure instead of the optic canal. They can also rarely arise from the clinoidal IC as well, which is also extradural. And very rarely they can also even arise from the middle meningeal artery. This ophthalmic artery will rarely give rise to intracranial perforating branches, and if they do, they'll usually supply the nearby structures itself, which will be the optic nerve, the chiasm, and the stalk. Now, in most commonly, the ophthalmic artery is going to be rising from the medial one-third of the superior wall of the ICA in 80% of cases. So this is superior wall, and usually in the medial one-third is where it will arise in 80%, and in 20% it will arise in the middle one-third of the wall. The origin of this ophthalmic artery can be quite variable in relation to the ACP, but it is important to remember that most arteries are going to be arising anterior to the tip of the anterior clinoid process and about 5 millimeters medial to it. So usually to access this ophthalmic artery, most likely you'll have to remove this anterior clinoid process. The posterior communicating artery, on the other hand, is the second branch, or the second significant branch of the C4, and it arises from the posterior-medial surface of the ICA. And it's about halfway between the origin of the ophthalmic artery and the ICA termination. After it arises from this posterior-medial surface, it will run medially and will sweep backwards to join the PCA. So where it joins the PCA is what defines the P1 and P2 segment of the PCA. If this artery, on the other hand, is fetal, if the PCA is fetal, that means that the PCOM is dominant. It is going to be running a little bit more backwards and more laterally. It can even be lateral to the third nerve, as we can see over here. So this is a normal PCOM, and this is a dominant PCOM, where P1 is hyperplastic, as you can see, as compared to the other side. And we can see it is running more laterally and even lateral to the third nerve. Sometimes the PCOM origin can be slightly dilated, and that can make it look like it's an aneurysm, but that is just known as the infundibulum of the PCOM, and it's found in about 6%. And so far, it is found to be neither aneurysmal or preaneurysmal. The posterior communicating artery has a lot of important structures of supply, and the perforators which arise from the PCOM are also quite important. So about 8 perforators will arise from the PCOM, and they will arise more commonly from the anterior part of the PCOM than they would from the posterior part of the PCOM. So the largest branch which will arise of the PCOM is known as the premammillary artery, or it is also known as the anterior thalamoperforating artery. And this will arise mostly in the middle third of the PCOM, and it will enter and supply the posterior, the floor of the third ventricle. It will also supply some very important structures, including the posterior hypothalamus and the anterior thalamus, as well as the posterior limb of the internal capsule. The perforators arising in front of this structure, the premammillary artery, are usually going to also supply the same structures, hypothalamus and the ventral thalamus. On the other hand, the perforators arise from posterior to the premammillary artery are going to be supplying the posterior perforated substance and the subthalamus. The third important branch of the supraclavian IC is known as the anterior choroidal artery. The anterior choroidal artery, as we know, is going to be arising distal to the origin of the ophthalmic artery and arise more laterally on the carotid wall than the ophthalmic artery will. It arises usually as a single artery, but can arise as two trunks or immediately bifurcate after its origin. In very, very rare cases, it can arise even from the MCA or the PCOM. At its origin, its size is going to be smaller than that of PCOM, but it is going to look similar to the ophthalmic artery in size. So it is one of the most important things to remember about the anterior choroidal artery origin is when you are clipping PCOM aneurysms, it is important to dissect out the anterior choroidal artery and preserve it. Another important thing is that there can be some perforators which are present between the origin of the PCOM and the origin of the anterior carotid artery. There may be one, two, or three perforators present, and these can sometimes get included in the clip that is being placed around the PCOM aneurysm. So these perforators, if you do end up damaging, there can be problems related to the optic tract, medial temporal lobe, and the posterior perforated substance. The anterior choroidal artery, after its origin from the IC, is going to be running posterior-medially, and then it is it is going to arise lateral to the optic tract. It will run along the optic tract and will cross from the lateral to the medial side. It is going to follow the optic tract and then end up reaching the lateral geniculate body. After it reaches that, it is again going to cross back to the medial to the lateral side. So as you can see, this is the optic tract over here, and this is the ICA. This is the anterior choroidal artery. As we can see, it is running from the lateral to the medial side of the optic tract, and then after it has reached what would be the lateral geniculate body in this region almost, it is crossing back from the medial to the lateral direction so that it can enter the ventricle over here. So it enters the crural cistern and then it enters the inferior choroidal point and enters the choroidal fissure to supply the temporal horn. So based on this course, it is divided into a cisternal segment, which is lying outside the temporal horn, and a plexal segment lying inside the temporal horn. The cisternal segment is further divided into a proximal and a distal portion by this lateral geniculate body, which should be approximately over here. There are multiple structures which are supplied from the cisternal part of the anterior choroidal. So it's important to remember it's not just the temporal horn choroid plexus which is supplied by the anterior choroidal artery, it's also multiple other structures as well. These some of these are quite important, but it is so these include the optic tract itself, since running along the optic tract will supply that. Other nearby structures are the uncus, the cerebral peduncle, the lateral geniculate body, the hippocampus, and the other medial temporal structures. The plexal segment obviously is going to supply the choroid plexus, and it can even supply the choroid plexus as far as the foramen of Monro. And it's also an important anastomotic point between the anterior and the posterior circulation, because the posterior circulation is going to give rise to the posterior choroidal arteries, which can anastomose with this anterior choroidal artery in the choroid plexus. So just a little bit more about these anastomoses. There are significant anastomoses which exist between the PCA and the anterior choroidal, not just along the choroid plexus, but also along the lateral surface of the lateral genicular body and near the uncus. Apart from that, there's also a marked interchangeability which happens between the PCOM and the anterior choroidal artery. So both of them arise from the ICA, and both of them are almost supplying similar structures with the perforators. So if a structure is not being supplied by the PCOM, it is going to be predominantly supplied by the anterior choroidal artery. So they can exchange their fields when it comes to supply of the internal capsule particularly. The PCOM branches will supply predominantly the genu and the anterior third of the posterior limb of internal capsule. The posterior two-thirds, on the other hand, will be supplied by the anterior choroidal branches. But there's no clear cutoff. If one artery is supplying more, the other will supply less. An important thing to remember about anterior choroidal artery is what happens if it is occluded. So there's a classic triad of anterior choroidal artery occlusion known as which includes hemiplegia, hemianesthesia, and hemianopsia. The hemiplegia and the hemianesthesia, as we know, happen because of involvement of the internal capsule. We know that the posterior two-thirds of the internal capsule will get infarcted because of lack of blood supply. And also, even the middle third of the cerebral peduncle can be involved. That is related to hemiplegia and hemianesthesia. The hemianopsia obviously happens because of infarction of the optic tract. So anterior choroidal artery occlusion was used previously for Parkinson's disease because the occlusion of the artery would also lead to an infarction of globus pallidus, which leave symptoms. But obviously is not used anymore. And symptoms are actually rarely seen with anterior choroidal artery occlusion because of significant collateral supply. But if this supply does not exist, then you can develop these features. Okay, so as we have discussed, we're going to be covering ACAs, MCAs, and PCAs in a separate discussion because it's a very long and extensive topic. So just for the last segment over here, I'll cover the infratentorial arteries. So, infratentorial arteries are a slightly complicated topic, and they're in a very small area. They're in the posterior fossa, and they're surrounded by a lot of important structures, including the brainstem, multiple cranial nerves. So, thankfully, they have been divided into three complexes, which can help us understand the anatomy and how to surgically approach them and figure out what structures surround them. So, there are three different neurovascular complexes. And it's important to remember that these are based on three specific arteries, three different parts of the brainstem, three different cerebellar surfaces, three different cerebellar peduncles, and three different fissures. And each complex will have its own different group of cranial nerves. So the upper complex is based on the superior cerebral artery and is going to this superior cerebral artery has a relation to the midbrain. It is going to be supplying the midbrain. It has a relation to the third, fourth, and fifth cranial nerve, to the cerebellomesencephalic fissure over here, the superior cerebellar peduncle over here, and to the tentorial surface of the cerebellum. The middle complex is situated on based on the ICA, and it is going to supply predominantly the pons. It is going to be related to the sixth, seventh, and eighth nerve, and to the middle cerebellar peduncle, the cerebellopontine fissure, and the petrosal or the anterior fissure of the cerebellum. The lower complex, on the other hand, it's going to be situated around the pica in relation to the medulla, the ninth, 10th, 11th, and 12th cranial nerves, which are arising from the medulla, the cerebellomedullary fissure, the inferior cerebellar peduncle, which will be located here, and the suboccipital of the inferior surface of the cerebellum. So coming to superior cerebellar artery, the segments of the superior cerebellar artery include, there are basically four segments of the superior cerebellar artery after its origin from the basilar artery. There is an anterior pontomesencephalic segment which is wrapping around the brainstem, and then there's a lateral pontomesencephalic segment. So there's no clear-cut margin of how you differentiate these two segments. The lateral pontomesencephalic segment is supposed to begin at the anterolateral margin of the brainstem, after which it will loop down. So this is the lateral pontomesencephalic segment. After it has crossed the lateral brainstem boundary, it will loop down, and it will almost or in 50% of cases actually touch the fifth nerve, root entry zone, following which will loop back up and continue running posteriorly. So here it is going to be running below the third nerve and below the fourth nerve, but above the fifth nerve. The anterior part of the lateral pontomesencephalic segment is going to be lying above the tentorium, but once it starts its caudal loop, the rest of the SCA ends up lying below the tentorial edge. The rest of the segments are the cerebellomesencephalic segment running in the cerebellomesencephalic fissure, and then the cortical segment is supplying the cortical branches to the cerebellum tentorial surface. So we know that the SCA is going to be arising from the basilar artery before the origin of the PCA. There have been cases where there has been an absence of superior cerebral artery completely. Most of these arise as a single trunk, but some of them, about 14%, can arise as duplicate trunks as well from the basilar. In only 4% of cases, the SCA itself can arise from the ECA itself. And if it arises from the posterior cerebral artery, it is going to be running above the third nerve and not below the third nerve. The height of this basilar bifurcation will determine what is the relationship of this SCA to the tentorial edge. Will it be above the tentorium or below the tentorium? The normal bifurcation of the basilar artery is supposed to be at the level of the pontomesencephalic junction. If this bifurcation is located above that, so if it is located in front of the midbrain, it is a high bifurcation. If it is located below that, above in front of the pons, it is a low bifurcation. A normal bifurcation is found in it was found in a study where it was done, and 18 out of 25 cases, and a high one in 6 cases. The low bifurcation in front of the pons is found only in 1 case. So in cases of a high bifurcation, the superior cerebral artery will originate above the tentorium, and in a low bifurcation will originate below the tentorium. In a normal bifurcation, which is the most common, it will originate just medial to the free edge of the tentorium. So after its origin, it's going to give rise to some important branches. So these include perforating branches which supply predominantly the brain stem. These branches can either be directly entering the brainstem, so these are known as direct perforating branches, or as we can see here, they can run around, they can wrap around the brainstem and then enter the brainstem. They're known as circumflex branches. If they run around for less than 90 degrees of the brainstem, then it is known as a short circumflex branch. If it runs around for more than 90 degrees of the brainstem, it is a long circumflex branch. Following its course, after it enters the cerebellomedullary, cerebellomesencephalic fissure over here, it is going to give rise to precerebellar arteries. These precerebral arteries are a dense collection of arteries which runs in the cerebellomesencephalic fissure. As many as 8 can be present, and it is very dense. So this is a very difficult area to dissect because of this reason, apart from the veins which will also be present here. These arteries are going to predominantly supply the cerebellar deep white hemisphere and also supply the dentate nuclei. So very important structures for cerebral activity. The cortical arteries, on the other hand, are going to be running out of the cerebellomesencephalic fissure and supplying the tentorial surface. This is a picture after removal of the tentorium, as we can see here. So these arteries can also spill over and supply a little bit of the petrosal surface and then spill down and supply a little bit of the suboccipital surface. They are divided into the vermian branches, which are 2, supplying the vermis, and the hemispheric branches, which are 3, supplying the hemisphere. There can also be something known as a marginal branch, which arises from the lateral pontomesencephalic segment quite anteriorly. It can even arise from the basilar artery sometimes. So this particular marginal branch is going to only supply the petrosal surface, not the tentorial surface. And it is basically a counterpart to the ICA supply of the tentorial of the petrosal surface. And there are frequent anastomosis which can develop between the ICA and marginal artery. The SCA is related to the oculomotor nerve, as we saw, and it usually is going to be passing below the oculomotor nerve. Unless the SCA is going to rise from the PCL, then we know it is going to pass above the oculomotor nerve, and then after that, it is going to follow its normal course. There can be a point where the SCA and the third nerve come in contact, and that usually happens about 4.5 millimeter from the origin of the artery. And sometimes this artery can compress the third nerve. If there is a duplicate origin, or it is originating low on the basilar artery, or there's a fetal PCA, there's less likely to have a point of contact between the SCA and the oculomotor nerve. The trochlear nerve, on the other hand, also runs in above the SCA, but has multiple points of contact with the SCA. But the point of contact basically matters only for the trigeminal nerve. The trigeminal nerve is going to be running below the superior cerebellar artery over here. And as we know, once the superior cerebellar artery crosses the lateral pontomesencephalic segment, it is going to loop down and it is going to try and touch the fifth nerve. So in 50% of cases, it does directly touch the fifth nerve and forms a point of contact. And this is one of the most common causes of neurovascular conflict in trigeminal neuralgia. So how can we approach and access the different areas of the superior cerebral artery? So the superior cerebral artery can be accessed and approached in different approaches to the basilar apex, to the tentorial incisura, to the trigeminal nerve, to the CP angle, to the pineal region, to the clivus and the upper part of the cerebellum. So all of it depends on what are the different areas of the vessel you want to access. So if you want to access the anterior segments of the SCA, you would use an anterior approach. Like if it is a high bifurcation, it will be above the tentorium, and so then you can use a tentorial craniotomy, open up the Lilliquist membrane, and that will allow you access to reach the SCA. Otherwise, if you're not able to access through that, you can also open up the cavernous sinus dura, and then drill out the dorsum sella and be able to access it through that. Obviously, this is a slightly more morbid approach than a tenorial craniotomy. The other approaches which come in from lateral, you could approach it from the subtemporal transtentorial approach, or a pre-sigmoid or a retrosigmoid approach. You can also, if you're approaching the quadrigeminal system, you can come in from posteriorly and use a subtemporal transtentorial approach or I'm sorry, this is a subtemporal. This has been copied here. So the posterior approaches would be the supracerebellar infratentorial approach and the occipital transtentorial approaches. Coming to the anterior inferior cerebral artery, the second important infratentorial artery, The anterior inferior cerebral artery, as we know, arises from the basilar artery, and there are multiple different segments of the anterior inferior cerebral artery. After its origin, it forms the anterior pontine segment, which is going to run in front of the pons. So this is a law. This is from its origin up to a line which is drawn upwards from the inferior part of the olive. Here, it is going to lie in contact with rootlets of the sixth nerve, as we can see over here. Following which, after that, it has a lateral pontine segment, and we know there's a cutoff which we draw up from the inferior olive to define the anterior and the lateral pontine segment. So here it begins at the anterolateral margin of the pons, and then it passes through the CP angle. Okay, and it can either do that above or below the seventh and eighth nerve, or between them. Here, it has three different segments. There's a pre-meatal segment before the meatus. There's a meatal segment, and there's a post-meatal segment of the ICA. So the pre-meatal segment is most likely going to be located anterior-inferior to the nerves. The meatal segment is going to be quite close to the IAC, and it will form a loop usually. This loop can touch the porus over here, sometimes can even go into the canal, and that happens in about half of cases. Then following is the post-meatal segment, and in the post-meatal segment, the artery will usually be lying posterior-inferior, superior or posterior to the nerves. But important to remember that this artery, the post-meatal artery, will never be lying anterior to the nerves. When we're approaching through the CP, through the retrosigmoid approach, so CP angle, this artery will always be lying behind the nerves. The important branches which arise from the ICA are the labyrinthine artery, recurrent perforating artery, and subarcuate artery. Following the lateral pontine segment, the next segment is the flocculo-peduncular segment. This flocculo-peduncular segment is going to be coursing above or below the flocculus to reach the middle cerebellar peduncle and the cerebellopontine fissure. Following which, it will then reach the cortical segment and supply the petrosal surface of the cerebellum. So the important thing about the origin of the basilar of the ICA is that it can arise from anywhere along the basilar artery, but most commonly arises usually from its lower half. There's also a lot of asymmetry between both the sides, and one ICA usually rises slightly above the other ICA. Most commonly rises as a single trunk, but as we have seen with a lot of other arteries, it can rise even as two trunks and very rarely as three trunks. The most important branch of the ICA is the labyrinthine artery, as we can see over here. This labyrinthine artery is going to be supplying the bone and the dura of the internal acoustic canal. Apart from that, the nerves within the canal, the seventh and the eighth nerve, also the inner ear structure, the vestibule and the cochlea. The labyrinthine artery has been variably defined by different authors, and so because of this definition, there's a lot of confusion. So supposedly 17% of the labyrinthine arteries can even directly arise from the basilar artery. Apart from that, if it is arising from the ICA, 77% of this will originate from the premeatal segment, 21% from the meatal segment, and 2% from the postmeatal segment. When it is entering the internal acoustic canal porus, it is always going to be lying anterior and inferior to the rest of the structures at the level of the IAC. So as we can see over here, after drilling the IAC, the artery is going to always be anterior as compared to the other structures which are located here. The other important branches which arise from the ICA include recurrent perforating arteries, a subarcuate artery, and some cortical branches. The recurrent perforating arteries are important because these actually originate from the ICA. They almost loop into the IAC, and then they come back and supply the brainstem. So if we're exploring this region, it is important to preserve these arteries because they're supplying the brainstem. There's also a subarcuate artery, which is not very well or very commonly talked about, but it is important because this subarcuate artery, it goes and supplies the dura of the subarcuate fossa, which is located lateral and superior to the internal acoustic canal. So so it enters here and then it supplies the petrous bone in region of the semicircular canals. So it is important because this can be a route of extension of infections coming from the masthead to the meninges. The anterior inferior cerebral artery, since all of it is lying anterior to the brainstem, can be approached by this by basically the lateral approaches to the CP angle, usually the retrosigmoid, the translabyrinthine, or the presigmoid approaches. Coming to the third most important, third and potentially the most important branch, which is supplying the infratentorial structures, that is the pica. The pica is the largest branch of the vertebral artery. And as we have already discussed, it usually originates intradurally, but it can also rarely originate extradurally. And if it does that, it has to penetrate through the dura along with the vertebral artery and come intradurally and supply the structures. So there are five segments of the pica. The five segments are the P1, which is the anterior medullary segment, which is going to run up till the most prominent portion of the olive. Following which, there is the lateral medullary segment, which is going to wrap around the brainstem, run behind, and it is going to be running from the most prominent portion of the olive up till the 9th, 10th, and 11th nerves. So over here, so these are 9th, 10th, and 11th nerves, and the part in front of this is the is the lateral medullary segment, and the part behind this is going to form the tonsillar medullary segment. So this tonsillar medullary segment is the part is going to begin at these nerve rootlets and then wrap around the medulla and enter the fissure between the medulla and the tonsil. So that is the tonsillar medullary segment. The fourth part, after it wraps around the medulla and enters this fissure, is going to the tilo-velo-tonsillar segment. So this begins where the pica start ascending along the medial surface of the tonsil, and then where the pica exits the fissure between the vermis, tonsil, and hemisphere, that is where this segment ends. That's a tilo-velo-tonsillar segment. It's a very tortuous segment over here, and it forms a convex rostral curve, which is called the cranial loop. The fifth segment is the cortical segment, which exits this fissure and supplies the cortex, that is predominantly the suboccipital surface of the cerebellum. The important branches which arise from the pica are the perforating arteries, which will wrap around the brainstem or directly supply it, forming the dilated circumflex perforating arteries. The choroidal segment, the choroidal branches rise only from the P4 segment and supply the choroid plexus of the fourth ventricle predominantly. And the cortical branches supplying both the vermis, the tonsil, and the hemisphere. So the operative exposures for the pica usually depends on the area of the pica that you're trying to approach. If you're trying to approach the pica anteriorly or laterally, we would obviously use a far lateral approach, or depending on the structures involved, the retrosigmoid craniotomy. If you're trying to approach the P4, the P5 segment of the pica, you have to do it through a midline suboccipital craniotomy, possibly a tilo-velo-tonsillar approach. So that is it for today's class. And as I said, we will be discussing ACAs, PCAs, and MCAs in a separate class, which I will just let you know the schedule for later. If there are any questions, you can please post them in the chat box and I will try to answer them.